It's a personal pleasure to introduce Dr. Joan Jeung, Professor of Pediatrics in the Division of Developmental Medicine at UCSF and Senior Associate Director of CalMAP, the California Child and Adolescent Mental Health Access Portal, which expanded the collaborative reach of pediatric, psychiatric, and behavioral services to children and youth with mental health care needs. Dr. Jeung also serves as director of the Resiliency Clinic at UCSF Benioff Children's Hospital, Oakland, Center for Child and Community Health, and provides developmental behavioral pediatric clinic services to patients and families. She is a staunch advocate for expanding access to mental health care and is founding executive committee member of the American Academy of Pediatrics Council on Healthy Mental and Emotional Development. She's been invited to speak on multiple venues on topics that vary from how clinicians can integrate mental health in practice to brief interventions for anxiety to helping children to manage emotions. Dr. Jeung will now talk about trauma-informed relational care.
Thank you so much for that kind introduction, and it's a great privilege and pleasure to be here. I will go ahead and start sharing my slides. Great. So today we will be talking about something very close to my heart, which is trauma-informed relational care models. And just a couple of things. I don't have any relevant financial disclosures to share. Today, I hope to describe what trauma-informed care is, the major principles of it, and why it particularly matters for when we're talking about patients with developmental disabilities. We'll talk a little bit about how we start the conversation, how we screen for or ask about potential trauma and resilience with sensitivity, hopefully without re-triggering our patients. Next, we will talk about how we use therapeutic communication skills, something we call common factors, as tools for communication and engagement. Finally, I want to close with some reflection about communication, about connection and community, and that role of that in resilience, as we so beautifully heard in our prior panel. So, what exactly is trauma-informed care? And I would argue more than any set of techniques, it really is a mindset, changing of how we see and how we hear in our clinical encounters. So I want to start with a story of Matt, not his real name, but my real patient. This is now an 8-year-old child with autism and intellectual developmental disabilities. He showed up really not speaking much and with clear global developmental delays and got diagnosed with autism somewhere between the age of 2.5 and 3. By the time I met him, he was 5 and he was living with his father in a car and really not connected to any services at all, as you could imagine. And with a lot of help from our social work team, they got him some income supports. They got him into school, little bit by little bit, bringing some services online. And it seemed like there was progress being made. But the last time I saw him in clinic, he was in 3rd grade. He was housed, but still not getting services. And as I was listening, he had gotten into a school, qualified for an IEP, but his father didn't want to send him and had stopped sending him. I didn't want ABA either, didn't seem to want ABA to come to their home. He had missed a number of appointments, was behind on his shots, and I was hearing some the father's interest in maybe some less proven therapies, even as he didn't want some what we consider evidence-based therapies. And so one of the fastest ways to get a pediatrician's hackles rising is to say you don't want vaccines for your kid. And so I could feel my own hackles rising. And I could start like feeling myself, asking myself, so what is wrong with this dad? But if we remember nothing else from this talk, we really need a shift in perspective. And I had to remind myself, it's not about what's wrong with them, but what happened to them. And so I had to remind myself of this. And digging underneath the surface a little bit, I knew about his previous trauma. Like in his first years, he lived with pretty severe neglect in a household where his caregiver had severe mental illness and substance use disorder. And so he moved in with his father at the age of 2. And due to community violence and some conflict with family members, this is what drove the family out into homelessness. And when I first met him, living in a car, and because of that, you can imagine how severe the insomnia was, and because of difficulties paying the phone bill, very hard to keep in touch with the family. And then finally, with all the difficulties in getting help, this very difficult journey was compounded by the father's injury and disability. He literally could not walk and was wheelchair bound for a while because of that injury. And then he started noticing after started sending his kid Matt to school, like there were unexplained injuries there. A kid was coming home with like bruises and going, "Whoa." But Matt couldn't explain what had happened. And so some growing distrust with the school. Car broke down, and hence the no-shows at appointments, and just a growing distrust of both educational and healthcare institutions. So, as Matt's story illustrates, here at the intersection of trauma and developmental disability is an area of heightened vulnerability. And there is strong evidence to suggest that people with intellectual and developmental disabilities have more adverse life events than those without IDD. And PTSD is likely underdiagnosed simply because of diagnostic overshadowing and symptom overlap, and to a certain degree, I think clinician reluctance to really ask about the trauma. So, digging a little bit into the numbers, here's some of the figures on exposure to adverse childhood experiences or ACEs, things like um, child maltreatment, neglect, or abuse, or mental illness in the family, or substance abuse in the family. So, among children with IDD or borderline intellectual functioning, you find that 82% have experienced at least one adverse childhood experience or ACE. 92% of those with borderline intellectual functioning have experienced an ACE, and 20% have experienced four or more ACEs, which is the highest risk category. Now, the rates are high among all US children, but lower than this. And so as we can see, children with developmental disabilities may have higher risks of exposure to ACEs. And going specifically into violence, and children with disabilities can face 3 to 4 times higher odds of experience violence compared with children without disabilities. And you can see some of the numbers here. About nearly 27% of children with developmental disabilities experiencing any form of violence at all, and really alarming numbers when it comes to physical and sexual violence as well. And so that's out in the community. When they come for help, as we again heard so eloquently from some of our prior panelists, even with the best of intentions, the medical system may introduce harm. And historically, there was like unspeakable harm with like some of our institutionalization practices and what happened there. But even in current medical encounters, the clinical language can sound pathologizing. Um, these are not always the most sensory friendly spaces. There's a lot of abrupt change. There's a lot of unpredictability. There's a lot of sensory overload. There are the actual painful, invasive medical procedures. And again, there can be some discomfort in talking about sensitive issues like trauma, which make it even harder to talk about. And so because trauma is so common, particularly among those with developmental differences, I argue that we need a change in clinical culture, and that is through trauma-informed care. And this really consists of a different way of seeing and hearing, communicating, and engaging with those who have experienced trauma and adversity. And this really is the heart of trauma-informed care. More than any set of techniques or like language pearls or anything else I can give you today, really is a different mindset and hopefully increasingly a different culture in our clinical spaces. So what exactly is trauma-informed care? This is really about some frame shifting questions that I want to share with you, as I shared before. It's not asking what's wrong with you, but what happened to you, and eventually what's strong with you. It's moving away from judgment towards empathy, curiosity, and real respect, really looking for some of the strengths. And I think this is a real culture change in medicine. A lot of what I learned in medical school really had to do with look for what's wrong and then fix it. So that brings us to the next big frame shifting question, moving from fixing towards understanding. because like literally a surgeon told me, go look for what's wrong and cut it out. And that's a lot of what we learn in medical school. But when it comes to chronic issues like developmental disabilities or the impact of trauma, especially complex trauma that affects our closest relationships, these are not amenable to quick fixes. These are multi-layered, very complex, multiple pieces, and it defies a quick fix. But if we can come with a posture of listening and understanding, we make ourselves 100% more useful to patients and families that we are actually trying to help. So there is a phrase that I want all of us to understand, and this is relational health. And relational health fundamentally consists of being able to form safe, stable, and nurturing relationships. Something that I've heard a lot in my work within the American Academy of Pediatrics, which describes trauma-informed care fundamentally as relational health care. And this really grew out of the scientific understanding that the best predictor of resilience in children who have experienced trauma is the presence of a safe, stable, nurturing caregiver in their lives. Somebody who's consistently available, somebody who is able to respond appropriately to their needs. This kind of love, nurturing relationship is like a shield that protects children from all the stressors that can come at them and helping the child's just whole body to reset from the effects of chronic stress, rest, and then heal from the biological effects of what we call toxic stress. Now, if this is true in, um, and I want to add here that a very wise colleague of mine, a developmental behavioral pediatrician, once told me, parental support is the closest thing that we have to vaccines in behavioral pediatrics. By really supporting parents in this hard but critical work of responsive caregiving, we can prevent a lot of the downstream sort of mental health concerns, like what we call behavioral health concerns. We can literally protect kids from this stress and help their brains to grow in a much healthier way, help their bodies to grow in a much healthier way. And so there's a lot of prevention we can do in primary care in particular, which is the world I've come from. And so let's think about ways that we can support caregivers, parents, families in this really, really critical work. And part of how we do this is we need to practice what we preach. If we are asking parents to provide the sort of responsive, safe, stable, nurturing caregiving, we need to infuse this kind of practice in our own clinical encounters. We need to treat that caregiver as we want that caregiver to treat their child. And not only model behavior we want to see, but as much as possible to infuse this kind of responsiveness, this kind of nurture into our communication with families. Some time ago, I ran into this model of autistic space, and for many of us may be familiar with this acronym of addressing sensory needs, providing predictability, really communicating acceptance of some of the differences in mindset and experience that people with neurodiversity bring, paying attention to our communication, and really building all of this off of empathy. I looked at this and said, this is the application of trauma-informed care into the care of autism and other neurodevelopmental differences. And so how do we construct the physical spaces, literally the physical spaces where care happens? How do we construct this listening, emotional holding space, as well as giving people some room to process all of the different things that are happening? I think this really is the application of trauma-informed care into the care of neurodevelopmental difference. And so now that we've talked a little bit about the main principles of trauma-informed care, I want to start making this practical and thinking about this process of communication. Because many pediatricians I know and respect very deeply are really afraid to ask about this because this is sensitive stuff. And the last thing we want to do is trigger somebody who is carrying a lot of stress. So how do we even introduce the conversation without doing harm? And so I want to share this question that's actually been studied and found to be highly acceptable. And this is the one I think is great for anybody who has any clinician who has a longitudinal relationship with a child and family. Since the last time I saw your child, has anything really scary or upsetting happened to your child or anyone in your family? And for those of us not in pediatrics, putting the patient, right, and in the context of the family. And I use this question in my own practice, and I have heard everything from the tricycle accident to I saw my dad pull out a gun and hold it to my older sister. So there is really the range here, but it's a nice open-ended question that allows the patient, allows the family to decide how much do they want to share with you in this moment. Here's another model that I really like, and this comes from the American Academy of Pediatrics and their foster care guide. And they really make the analogy here between how, like, just like fever often means the body is fighting infection, things you've talked about, like sleep problems, acting out, some behavior concerns, they often signal that the child is facing like really stressful thing or even some kind of threat. And do you have any concerns that your child may be experiencing something like this? So those are some questions that we might ask, and hopefully in a way that is open-ended enough and non-stigmatizing. There has been a movement to use some trauma screening tools, and many of us might be familiar with a school screening tool called the PEARLS or the Pediatric ACEs and related life event screener that developed in the San Francisco Bay Area and actually in collaboration with UCSF. Um, Many clinicians I know who use this also pair this with the resilience questions, like how does your family cope with stress? Or what are some things you like to do together as a family? Or what is your child good at? So pairing them with resilience questions often helps to create a more balanced kind of conversation. But the value of screening really is about opening a conversation rather than specific disclosure. It's sending the signal that this stuff matters to your, the patient's health, to the family, and we are open to hearing. Another approach really is to look for social drivers of health, things like housing insecurity, food insecurity, parenting stress, caregiver depression. And there are some wonderful screening tools I've listed here on this slide that can be used for this purpose. Wonderful, especially if you have, as part of your medical home team, a case manager or social worker or health navigator, somebody who is then able to link the family to needed resources that you identify through the screening. And in addition to like open-ended questions and screening tools, I take a step back and really look at behavior because very often, especially in children, behavior is communication. And so for the younger children or for those who are not speaking as much, clinginess, crying, difficulty in consoling, sleep problems, regression in skills, this may be a signal that there's something really stressful, a big problem they can't fix and that they don't know how to address on their own, and an invitation to look deeper. Many things can cause this, but it's an invitation to look deeper. Older children may have problems with learning or concentration, again, sleep problems, anxiety, some of this acting out behavior, some social peer difficulties, as well as low mood. All of this is invitation to look deeper and something that we really want to stress with families and caregivers who might be really frustrated by some of the behaviors that they're seeing. When a child who has experienced trauma or significant adversity is acting in these ways, they are not being bad, okay, quote unquote. These are normal responses to abnormal circumstances. This is exactly what we expect to see. This is a child's nervous system trying to keep them safe. And this behavior is trying to communicate something to us. So let's try to listen. So here's another big question I want to pose, and another question that causes many wonderful clinicians that I know a big pause. It's like, we don't want to ask because once we know, how do we respond? And what do we do? And I think we all in the clinical space have experienced that moment. Okay, this is big. Now what? What do we do? And we bring help. And HELP is an acronym that stands for hope, empathy, language and loyalty, permission, asking permission before we go into the hard stuff, establishing partnership, and then co-creating a plan. So let's dive into this a little bit further. Um, I want to say that these are what we call common factors of psychotherapy. There are many different kinds of psychotherapy for mental health needs, but they share certain common elements and they have to do with therapeutic communication. How you talk with, communicate with, and engage with patients or clients and their families. And some of the leaders in the field have have asserted that this therapeutic alliance that you're building through these communication skills, that accounts for up to half of the benefit of psychotherapy. And guess what? You don't need to be a therapist in order to offer these things. So H is for hope. Just the idea that adversity is not destiny. And think about this like balance beam. Lots of adversities, lots of difficulties that might tip outcomes in a negative direction. But this is not a fixed thing. By building in supports and family supports and strengthening the network of supportive relationships around a child, around a patient, around that family, we can really tip those outcomes. And knowing just how vital supportive relationships are, we can really try to bring in the resources to help move the circumstances in that direction. Again, this is from one of the prior AAP presidents. This idea that relationships are a vital sign. Just as we're checking blood pressure and heart rate and weight and height, let's look at the relationships in the room and see what is that telling us about the direction that this patient and family might be going. So many of us have heard of the Adverse Childhood Experiences study, but I want to tell you about the Positive Childhood Experiences study. Just as there's a dose response relationship between the number of adversities and poor outcomes. There is a dose response relationship between these positive childhood experiences and better outcomes in health in adulthood. And look at how relational these experiences are, being supported by your family, being able to talk with your family about these things, participating in community events and really enjoying it, having a sense of belonging in your high school, having other adults taking an interest in your life. These things, the more these things happen in your childhood, the better the outcomes, even in the presence of trauma and adversity. So this is all hope. We can offer a lot of hope to families, knowing that outcomes are not fixed and we can make a difference. E is for empathy. Just the idea that listening and how we listen can also make a big difference. And this was a big frame shifting understanding for me because I often felt very helpless hearing about some of these complex traumas and going, what can I do? But just by offering empathic listening, somebody once told me, I am doing something and doing something really important. And the person who taught me was a parent. She had a child with borderline, like some borderline intellectual functioning, some developmental delays. And I asked her, do you have any tips for pediatricians like me as to how to help families? Like, 'cause she had made it through some really tough circumstances, including domestic violence and like basically physical violence in her home directed against herself. And she had made it out to safety and became the beloved director of her neighborhood preschool. She had been through quite a journey. And she told me, listen, just listen. Because this is what opened the door for help for her. Is when her son's pediatrician just sat and listened to her. She said, this was the open doorway to the help that she needed step by step to bring her family to safety and to get the help that she and her children needed. L stands for language and loyalty. And really, this is a rapport building tool to use the same language as the patient or caregiver, trying to avoid clinical language, and of course, expressing some loyalty. You're not in this alone. We have a team here. We're going to do all that we can together to try and take steps to move the needle in a more positive direction. Here's some strength-based language pearls that I have picked up along the way. Like, tell me something you like about your child. What's something good that you are good at? Directly asking to the patient. What are some things that help you or your family to get through stress or hard times? And tell me things that you like to do together. These are all wonderful strengths-based questions, great ways to start out a conversation so that as you get to some of the more challenging things that we've started out from a stronger place. And noticing, acknowledging something the patient or the parent is doing well. Like, I saw how quickly you moved, like, to comfort your child as they went through vaccines. Beautiful. And how quickly they calmed down. There is so much just wonderful care that's happening here. P stands for permission and partnership. Asking the permission before asking about the hard stuff. Can we please talk about? Okay. And then the partnership. We'll work on this together. And instead of the 10-part plan, maybe we can break it down and pick one or two things, co-creating that plan with the family. And again, just starting to move in the right direction. Now, these are all things that we can do as non-mental health specialists. No matter where we are, we can offer help. But for many kids who have been through trauma, who are experiencing PTSD, or who are experiencing like other like mental health or developmental effects of that trauma exposure, there are evidence-based therapies for that traumatic stress exposure. And these are some of the evidence-based interventions listed here on the slide, depending on what age the child is at. So child-parent psychotherapy is what we call a dyadic therapy, really looking at that attachment relationship between caregiver and child and trying to bolster that relationship through the therapy. This is for the youngest kids who are experiencing traumatic stress. And then again, other forms of therapy you see here, and then trauma-focused CBT, really being the evidence-based therapy for those who can go through talk therapy and who are experiencing PTSD. So I just want to end with a thought about being with. This is from we based our resilience clinic at Benny F. Children's Hospital, Oakland, on this intervention called Circle of Security. And what struck me about this is those hands on the circle. Those hands is that safe, stable, nurturing caregiver holding the child. There's a concept here called being with. And being with is basically emotional availability and presence, like attention, moments of this undivided attention and connection with your child. And these are the building blocks of secure attachment and that safe, stable, nurturing relationship. This is how that attachment, these relationships form um, through being with, just being emotionally present, and importantly, a calm emotional presence that isn't overwhelmed by the tears, by the needs, by the tantrums, by all the ways in which children can communicate their needs through their behavior. So being bigger, wiser, stronger, wiser, and kind. And if we are asking parents and caregivers to do this with their children, we need to be prepared to help hold the caregivers as well. There's this idea of like, those hands also need some holding, right? So we as healthcare providers can be those hands holding hands, providing the same kind of holding for families. And this is a big job, but we can practice being with our patients and our families and helping to build this kind of like circle of security around the child, around the patient, around that family. Another phrase I loved was good enough parenting. And this also came from Circle Security because there is no such thing as a perfect parent or caregiver. There is no such thing as a perfect pediatrician or healthcare provider. We are all just trying to be good enough. Nobody needs perfection because perfection doesn't exist. What is needed is presence and positive intentions. And when ruptures come, because that just comes with the territory of relationships, when ruptures come, we just seek to repair and to do our best to repair. And that is good enough. And there is something in that process of rupture and repair that actually strengthens that relationship, that actually builds resilience, that actually helps children to experience stress and overcome it and say, hey, the world didn't end because we had this conflict. And the attachment literature suggests 30% of like connected, attuned responses is good enough for solid attachments to form. So this gives me hope as a parent and also as a pediatrician that what's needed really is that presence and positive attention. So just want to end with this thought that relationships really are the key to resilience. The relationships that happen between the caregiver and child, and the relationships that we are seeking to build in hopefully a trauma-informed space that we are increasingly, hopefully building within healthcare spaces. And these are our aspirations to listen and to be with our patients and families, to bring hope, empathy, language and loyalty, asking permission, building partnership, co-creating maybe hopefully achievable plans. And in all these ways, supporting those safe, stable, and nurturing relationships that build resilience. And so thank you so much for coming and listening. And with this, we'll take questions.
Joanne, thank you so much for delineating trauma-informed care, especially describing the need for cultural change and also offering really some practical tips for everybody. Um, and so I have a sort of a question that might be a little bit from the side, but starting
Mhm.
last year, pediatric
Mhm.
residents are required to receive 4 weeks of training in mental health care.
Yes,
And I
yes.
realize this is still early on, and I'm wondering
Mhm.
if you can comment on how such training is including mental health care for children, youth, and young adults with developmental disabilities, and whether you know of any models.
This is an excellent question. And I think our medical education in some ways reflects the silos over various disciplines. And so developmental behavioral pediatrics being one rotation, and then mental health being a different rotation. And I don't know of great models that actually bring these together to specifically address mental health needs within, you know, in this community of children with special health care needs. But I agree that this is very much a need. One of the ways in which I really love the AAP or the American Academy of Pediatrics approach to mental health care is this idea there are certain skills that cross over diagnoses, right? And these therapeutic communication skills being some of those skills that really cross over many different diagnoses. And I think that this has entered like medical education, like and training and resident education. And so I'm very happy to know that this is some of the trauma-informed care education that we are providing, at least here at UCSF, in trying to teach these kinds of communication skills. And I hope more of this is taking root across the country.
Okay, thank you so much. I know it's early and there's plenty of
Yes.
room for change. There's some questions from the Q&A. So the first one is more about the screening process. Um, Wondering about informed consent around mandated reporting before screening for
Yes.
trauma.
We do not routinely get informed consent before giving out something like the pearls, as far as I know. But usually when the pearls is used, it's done in a de-identified, it's done in a way where you just, instead of circling which of these things happened to you, you just put two of these things happened to me, right? Or two of these things have happened to my child. And so you do not have to make a specific disclosure around what happened, but you can open that conversation about there's a lot of stress happening in the family right now. And that was specifically to get around these really sticky issues of mandated reporting. And this is part of the reason why I personally like asking open-ended questions, because this puts a lot of control back into the hands of the patient and the family. What are they ready to disclose? What are they ready to share? What are they specifically asking for help with right now?
Another question. Um, so this is a long one. It is often hard to find the balance between being present and available for the
Yes.
caregiver, honoring their
Yes.
trauma, fear, etc., but ensuring the needs of the person is actually still being met.
Yes. Yes.
Sometimes there is a major barrier of caregiver trauma limiting child adult
Yes.
or the child or adult's
Yes.
ability and
Yes.
opportunity, or flat
Mhm.
out being affected, leaving the child adult
Yes.
with neglect, isolation, and denial of their rights, etc.
Yes.
Having these
Yes.
really honest conversations are so difficult. So maybe this is more of a
Absolutely.
comment, but yeah.
Yes. 100% that um, these things can affect multiple generations. These kinds of experiences can affect multiple generations. And those ghosts in the nursery can cast such a long shadow. Uh, as another practical tool, I think it's so helpful to have private one-on-one conversations with a parent that can be really frank and open so that we can keep conversations that involve that child more positive, because we want to prevent harm in these settings. And so the degree to which we can have that holding space that's just for the parent and where some of this can come out and where we can connect the parent to their own help so they can start processing some of what happened to them as well, so that we can keep the encounters with children more positive, I think would be really, really important. And so it's just something that we have to keep in mind as we're asking some of the questions that we're asking. Other thing is just I often like to tell the parents, permission to take care of yourself, because the more well you are, the better this will be for your child. Right? So this is just really important.
So really just supporting not only the child, but also the parent who's supporting the child.
Yes. But to see the kid too. And so I think it's super important to have that space alone with the child as they get to be old enough to interact directly with you.
Okay, great, thank you. Um, and then this might be the final question. Dr. Jeung, this is from Dr. Ben Meisel from CCS. Um, are you involved in the work being started at BCHO to roll out a survey in the emergency department for families with a child with behavioral developmental needs to help get that child a space experience? And if not, would love to connect with you. Um,
Mhm.
to support for families of children with disabilities, organization working with BCHO, that's Benioff Children's Hospital Oakland,
Right.
to make this happen and improve emergency care for autistic children, young adults, and others with behavioral conditions.
I am not part of that and would love to hear more.
Okay, great. Well, I guess more to come, but thank you so very much for explaining so many things and I guess putting hope in terms of the work that we do.
Thank you so much for the opportunity. Pleasure to be here.